Physiology of circulation, Part 2. Capillaries are a collection of narrow branching blood vessels that are located between the arterioles and the venules. The capillary walls are a single endothelial cell thick with a small amount of basement membrane. They are specialized sites for gas, nutrient, fluid, and waste exchange that occurs between the circulating blood and the tissues. The rate of exchange is based upon the size, solubility, and charge of the substances, as well as by the charge, abundance, and size of the pores between the endothelial cells. Capillary types have different permeabilities. Continuous are the least permeable, yet they are the most abundant type and are found throughout all the tissues. The pores are too small to permit movement of plasma proteins, so they remain in the vessel and they exert a force called colloid osmotic pressure that helps retain fluid within the capillary lumen. Fenestrated, these are intermittent permeability. They allow higher rates of fluid exchange and greater exchange of molecules such as small proteins. Sinusoids are the most permeable. These are modified capillaries with large gaps between the endothelial cells, and they have a discontinuous basement membrane. Continuous. These are found in most of the tissues. Plasma proteins cannot pass through. So the only exceptions to this are the blood-brain barrier, the cerebral vessel endothelial cells that are conjoined by tight junctions. Fenestrated capillaries are found in organs that have a high rate of exchange between blood and tissue. So the kidneys, GI tract, they have fenestrations and they do allow water and some soluble movement as needed for the functioning of organs. The discontinuous or the sinusoid capillaries, these allow the greatest amount of movement and allow proteins to move between in and out of the cells. So things that are highly vascular, like your spleen, will be an organ that would have discontinuous capillaries. The net fluid exchange across the capillary walls is influenced by the capillary and interstitial pressures. Both sides have hydrostatic pressure that push water and small dissolved molecules away from the source across the capillary walls. Both regions also have a colloid osmotic pressure created by proteins that have little ability to move across capillary walls. The colloid osmotic pressure pulls water and small dissolved particles toward the source across the capillary walls. The rate of transport is also influenced by a filtration coefficient that is affected by the density and properties of the filtration pores. The values for capillary and interstitial hydrostatic pressure vary in different tissues and organs. In some, interstitial hydrostatic pressure is negative and it favors filtration. Capillary colloid osmotic pressure is not as variable, although it does change in the long term when looking at the context of liver production of plasma proteins. Capillary filtration is relatively high in arteriolar end of the capillary, but a substantial portion is reabsorbed in the venous end of the capillary. Normal filtration and reabsorption along a typical capillary in the systematic circulation. Black arrows in the image represent the magnitude and the direction of fluid exchange. The pressure values are shown in millimeters of mercury. Hydrostatic pressures at the arteriolar and the venous ends are shown in their respective locations. The yellow rectangle represents the pressure that is in the interstitium, and the numbers in parentheses indicate the effective filtration pressures at the arteriolar and the venular end of the capillary. The value of capillary colloid osmotic or ontic pressure is displayed within the capillary. Interstitial fluid arising from capillary filtration forms lymph that returns to the circulation via an extensive specialized network of lymphatic capillaries. Beyond the feeder capillaries, the lymph vessels become lined with smooth muscle that slowly contracts when filled with lymph. Lymph vessels eventually converge at lymph nodes that will filter fluid proteins and are active in the immune response. Arteriolar vasodilation allows higher hydrostatic pressure to be sustained to the level of the capillaries. This enhances the rate of lymph formation to the extent that it can actually exceed the clearance rate of the lymphatics. Vasodilatory edema is a hallmark of local inflammation. When tissue trauma triggers an innate immune response, histamine is released into the region. Histamine promotes vasodilation and increased capillary permeability, both which favor filtration over reabsorption and produce the cardinal inflammatory sign of swelling. Venous obstruction of deep venous thromboses increases venous pressure in the affected region, which is routinely the leg. This pressure greatly increases the capillary hydrostatic pressure and promotes filtration along the capillary length. This is manifested by edema in the affected limb. Right-sided heart failure is known to cause fluid retention and increase systemic venous pressures. It also promotes peripheral edema that is most prominent in the dependent body regions of the feet and ankles. Diuretics are often used to enhance water excretion, reduce capillary hydrostatic pressures, and reduce edema. Venous hypertension can occur in the legs, particularly in an older adult, and this is due to incompetence of venous valves and decreased effectiveness of leg muscle activity to compress the leg veins. One of the main signs of this syndrome of venous insufficiency is ankle edema. Liver disease, malnutrition, and some kidney diseases can lead to reductions of circulating albumin and other proteins, therefore reducing the colloid osmotic pressure. The loss of the restoring force favors reabsorption and promotes widespread edema. Hemodilution that reduces colloid osmotic pressure is also a prevalent scenario in emergency departments where patients are volume expanded with intravenous fluids that contain glucose and electrolytes, but no proteins. This is routinely done after a major hemorrhagic loss. Although relatively rare, any condition that impairs the return of lymph to the circulation will also cause the lymph to accumulate and edema to form. In patients with cancer, a variety of sites may develop tumors that block lymph flow and promote edema of the affected region. Several parasites are also known to impair lymph flow. The most common recognized is Wucheria bancrofti. This causes lymphatic filariasis, often referred to as elephantitis. The opposite changes in capillary Starling forces and fluid movements are seen in the pathophysiological adaptation to severe hypotension and hypovolemia. The baroreflexes promote intense sympathetic vasoconstriction that maintains arterial pressure but greatly reduces the capillary hydrostatic pressure. The balance of Starling forces now favor reabsorption of fluid along the length of the capillaries, a phenomenon that is sometimes known as autotransfusion. The loss of skin turgor is a physical manifestation of this fluid shift, especially in children and youth who have an abundance of tissue elasticity. This is less prominent in an older adult because they have reduced elasticity of the skin and interstitial tissues. Their capillary refill is also slowed due to generalized vasoconstriction. Veins have a greater radius with proportionally thinner walls and smooth muscle layers as compared to arteries and arterioles. The downside of the structuring of veins is that they are prone to dilation and deformation when they are exposed to high intravascular pressure. The two types of veins that drain the legs are the superficial veins and the deep veins. The deep veins are surrounded by muscles, and muscle compression assists the flow of blood uphill against the force of gravity to larger collecting veins. Venous pressure in the legs increases while in the standing position and then decreases when walking. This is the anatomy of leg veins. A is normal conditions and B with venous hypertension. The venous drainage of the leg is through deep and superficial veins that are connected by perforator veins. Gravitational pull on the blood increases venous pressure as shown in the blue boxes. The numbers are pressures in millimeters of mercury. The highest venous pressure are at the feet and the ankles. Contractions of leg muscles compress the deep veins and facilitate their emptying, therefore reducing venous pressure. Perforator veins allow superficial veins to drain to the deep veins that are emptied by the muscle pump. With aging or primary venous disease, superficial veins will fail to empty and become tortuous and dilated. The flow from deep veins can reflux into superficial veins and worsening pressures and dilation that will ultimately contribute to valve incompetence. Veins have bicuspid valves at regular intervals that close behind the blood flowing upward to the vena cava. Competent valves prevent reflux toward the feet. Risk factors for varicose veins include occupations that involves a lot of time standing, family history, multiple pregnancies, obesity, and congenital valve dysfunction. The increase in venous pressures can lead to increased vessel diameter and length. This results in the tortuous, bulging veins, particularly affecting the superficial veins. A distinguishing characteristic between venous and arterial malfunction is that the pain associated with venous disorders will lessen with physical activity, whereas the peripheral arterial disorders generally have increased pain with physical activity. Hypertension is the most common disorder of the circulatory system in children, and the prevalence, unfortunately, is increasing, often due to sedentary lifestyle, obesity, and type 2 diabetes. The clinical significance of early identification and treatment of pediatric hypertension is high. Pediatric hypertension induces early vascular aging. The types of vascular changes associated with aging can include vascular wall stiffness, inflammation, endothelial damage, and increased left ventricular mass. These are promoted in children with hypertension, therefore accelerating their development of cardiovascular disease in later life. Blood vessels are dynamic structures that are remodeled by complex pathways throughout the lifespan. Remodeling of the vascular system with aging influences both the structural and functional changes of nearly all the other organ systems in the body, especially the heart. Two major changes that occur in the arteries due to aging are endothelial dysfunction and increased arterial stiffness, or arteriosclerosis. This is an image that shows the molecular mechanisms that increase arterial stiffness with aging and hemodynamic consequences. MMPs are the matrix melanoproteinases, and AGEs are advanced glycation end products. In summary, the systemic vascular system distributes blood out through the left side of the heart. The aorta and the large arteries receive the systolic pressure and the volume pulse. Their walls are thick to help protect against damage, but the endothelial lining is very delicate and it is subjected to injury when there is turbulent flow, shear stress, or other irritants. The arterioles are narrower than the arteries. The arterial wall does have smooth muscle. It helps to regulate the diameter and vascular resistance and controls the blood pressure. Many of the mediators that alter the flow of blood, causing either constriction or dilation. Norepinephrine is a vasoconstrictor. Endothelial nitric oxide is a vasodilator. Capillaries are very small vessels and they have increased permeability to help exchange fluid and substances. Their hydrostatic pressure promotes fluid through the capillary walls. The colloid osmotic pressure promotes fluid movement into the capillaries, and any imbalance can result from many physiological and pathophysiological disease processes or states. Often it causes edema. Veins have thin walls. They are vulnerable to dilation and lengthening when they have an increased volume and pressure. Therefore, they are now becoming varicose veins. Any reduced flow in the venous system can cause clot formation and venous hypertension.